sensory symptoms are there. It can be anywhere, in the root or in the cord, in the nerve. How to say it is in the nerve? The sensory loss will be confined to the region supplied by the nerve. For example, if the person has a carpal tunnel syndrome, the sensory loss will be in the median distribution of the fingers. So, there will not be any sensory disturbance in the forearm. But paresthesia and pain may be experienced beyond the region supplied by the nerve. So, carpal tunnel patients, though the problem is the median nerve compression at the wrist, the sensory loss is only this area, but the pain and paresthesia may extend up to forearm, rarely to the arm, but never to the neck. So, that we have to be very clear. In a carpal tunnel syndrome, the sensory loss may be only the tip of the median distribution of the fingers, but the pain and paresthesia may extend up to the forearm, rarely to the arm, but never to the neck. So, the area of pain and paresthesia may be beyond the nerve supply. That we have to be very clear, especially when you are evaluating compressive mononeuropathy. All sensory modalities are affected as the peripheral nerve is concerned, and but in nerve lesions, the area of loss of touch sensation, that is anesthesia, may be larger than the area of loss of pain sensation. Anesthesia may be more than the analgesia. Polyneuropathy produces graded distal symmetric sensory deficits which are length dependent, what we call as a glove and stockings pattern of sensory loss, that what you hear. So, you can see this is glove and stockings type, again it is graded. The more severe involvement is the feet and less severe is at the knee region. I will come to that point later. The graded sensory loss is different from non-graded sensory loss as far as the glove and stockings type of sensory loss is concerned. We will discuss when you are discussing the myelopathy. Coming to the root lesions may not cause severe sensory loss because there will be overlap between the adjacent dermatome. So, C6 root causes sensory loss over the thumb, whereas C7 causes the index and middle finger. So, there may be overlap, and this you have to be very clear when you are evaluating of radicular type of sensory loss. Again, all modalities are affected, but in root lesion, analgesia will be more than the anesthesia in contrast to the nerve lesion. The root pain is usually radicular, which is typically sharp, lancinating, electric shock like pain radiating along the distribution of the nerve root. It starts as a C5, it starts from here and it goes here. It is often exacerbated by coughing, sneezing or straining. Because why I am stressing this, radicular pain may be seen in diabetic neuropathy and tabes dorsalis. There is no compression. So, your straining or coughing or sneezing methods may not exacerbate the pain, that you have to be clear. When a person comes with a radicular pain, we generally think there is a root compression, may not be there. Pseudo-radicular sensory loss can occur in thalamic lesion, but very rare. So, they may present with C5, C6 sensory loss. When you carefully see, there will be a sudden onset of sensory loss. Sometimes they may have a pseudo-radicular pattern in the thalamic lesion. So, this type of sensory loss what you see in the picture, and you can attempt, most often this happens, already we discussed it, C8 and T1 region. So, then this is mostly C6 region. In between what you see not shaded area is C7. So, by looking at the area of sensory loss, we may say is it the radicular dermatomal pattern or the peripheral nerve pattern. Coming to the sensory ganglion lesion, ganglionopathy or sensory neuronopathy, the sensory loss is very severe and all modalities of sensation are lost and they usually present with severe sensory ataxia. Asymmetric and non-length dependent sensory loss is the classic finding. Usually it is either paraneoplastic or autoimmune origin, especially Sjogren syndrome can present as a severe ataxic sensory ganglionopathy. Sometimes the spinal cord lesions may mimic like a peripheral neuropathy. Spinal cord lesions usually present as a cross sensory loss, or the tract will be involved. Pain and temperature will be involved in the one side, and position and vibration sense will be involved in the other side. So, ipsilateral pain and position sense and vibration loss, the opposite is that pain and temperature loss. That is the way that we divide. But this is for the tract. 75% of the patients may have sensory phenomena and posterior column sensory loss starting in the upper limb. So, that may confuse with some type of radiculopathy, sometimes of peripheral neuropathy involving the upper limb predominantly. Most common site of paresthesia is in the 4th or 5th digits, because the greater size of fasciculus cuneatus as compared with fasciculus gracilis above the cervical segment may explain this greater loss of paresthesia in C4, the 4th and 5th digits. That we have to be very clear, because that may be confused as a ulnar neuropathy. Sometimes the sensory loss is limited to little finger, or only the 2-point discrimination may alone be affected in a myelopathy. What is more interesting is that a myelopathy, especially cervical, can present as a glove and stocking type of sensory loss. How? Or it can present as a numb clumsy hand syndrome. So, that also can be confused with peripheral neuropathy. Two types of sensory loss. One, glove and stocking, which is graded. Glove and stocking which is graded is more in favor of peripheral neuropathy. Glove and stocking which is not graded, abruptly finishing, or onset both upper and lower limb simultaneously, it is more in favor of myelopathy. Whereas, it is a glove and stocking starting in the leg, slowly coming up. By the time it crosses the ankle, it involves the tips of the finger. By the time it crosses the knee, it involves the hand. That is called graded sensory loss, is classic for peripheral neuropathy. We divide clinically pure motor, sensory, combined or autonomic, because the pure motor gives some clue about the etiological diagnosis. Pure motor, acute subacute, we can generally think about lead intoxication, acute porphyria, multifocal motor neuropathy, Guillain-Barré syndrome or diabetic hemotopic. Whereas a chronic CADP, hereditary motor neuropathies, motor neuron disease, ALS. Sensory ataxic neuropathy, ganglionopathy, most often it is Sjogren, paraneoplastic, cisplatin, vitamin B6 toxicity, HIV related sensory neuronopathy or idiopathic sensory neuronopathy. Predominantly with the autonomic neuropathy, we generally think if it is acute Guillain-Barré syndrome, vincristine induced neuropathy or porphyria, idiopathic pan-dysautonomia. In chronic cases, hereditary sensory autonomic neuropathy, diabetes, amyloidosis, HIV related autonomic neuropathy and paraneoplastic sensory neuropathy. These all the things can present as autonomic failure. Small fiber neuropathy is known for painful sensory neuropathy, because the small fibers, unmyelinated fibers are affected, or myelinated, thinly myelinated fibers may be affected. So, the problem will be of pain and paresthesia in these patients. Loss of sensation will not be obvious in these cases. Diabetes, vasculitis, Sjogren, celiac, HIV-related symmetric polyneuropathy, Fibres, Stangius, amyloid and toxins, especially arsenic and thallium, we may consider in cases of small fiber neuropathy.